Nobody expects it to happen the way it does. There is no alarm, no obvious warning, no moment where the body raises its hand and announces that something has shifted. It happens the way water carves stone, so gradually, so silently, that by the time anyone notices, the change has already been underway for months, sometimes years. And in many cases, the thing doing the carving isn't a disease at all. It's a medication, one that was prescribed thoughtfully, taken faithfully, and never questioned. Because why would it be? It was working. Nothing felt wrong. The prescription was filled, the pills were taken, and life continued. But inside the body, after 60, the rules had quietly changed, and nobody told the prescription. This is the conversation most people never have with their doctor. Not because doctors aren't skilled or caring, but because it sits in a gap that modern medicine rarely addresses directly. We talk about starting medications. We talk about what they treat and what side effects to watch for in the first few weeks. What we talk about far less often is this. What happens to a medication that made perfect sense at 50 when the body that's taking it is now 65? What happens when the liver that once cleared a drug efficiently is working at a slower pace? What happens when the kidneys that filtered away excess compounds are now filtering with less precision? What happens when arteries that once absorbed fluctuations in blood flow are now stiffer, less forgiving, less able to adapt? The answer, in too many cases, is that a medication which once provided protection quietly begins to provide something else. Not because it changed, because the body it's working inside has changed around it. And that difference, invisible as it is, can be the difference between stability and a heart attack, between protection and a stroke, between a routine morning and a medical emergency that seemed to come from nowhere. It didn't come from nowhere, it was building. And today I want to walk you through exactly how and with which 5 types of medication that buildup most often happens. Not to frighten you, not to make you distrust your prescriptions or your physician, but because the most powerful thing any person over 60 can do for their cardiovascular health isn't found in a supplement or a new exercise program. It's found in understanding the full picture of what their body is currently managing, and making sure that picture is being regularly and honestly reviewed. Before we get to the medications themselves, you need to understand the biological foundation underneath all of this, because once you do, everything else will make immediate sense. After the age of 60, several systems that govern how your body handles medication begin to shift. The liver, which metabolizes the majority of pharmaceutical drugs, processes them more slowly than it once did. This isn't disease, it's normal aging. But the practical consequence is significant. Drugs that once moved through your system in a predictable window of time now stay longer, sometimes considerably longer. And a drug that lingers becomes, in effect, a higher dose than what was actually prescribed. Your kidneys undergo a parallel change. Their filtering efficiency decreases gradually with age, meaning that substances which once left your blood quickly through urine now take longer to clear. Again, not illness, normal biological aging, but meaningful pharmacologically. And then there are your blood vessels. With age, arterial walls become less elastic. The endothelium, that extraordinarily thin inner lining of your blood vessels that controls blood flow, regulates clotting, and manages how blood pressure rises and falls, becomes more sensitive to disruption, less resilient, less forgiving of anything that pushes against its delicate balance. This is the landscape into which every pill you take arrives each day, a landscape that has changed, often without your awareness, and often without your prescriptions being adjusted to reflect that change. The first medication that deserves your full attention is one of the most commonly reached for substances in the world. Non-steroidal anti-inflammatory drugs, known as NSAIDs, sit in almost every medicine cabinet. Ibuprofen, naproxen, and their prescription-strength relatives are used daily by millions of older adults for joint pain, arthritis, back pain, and inflammation of all kinds. The relief they provide is real and often immediate, but what they are also doing, consistently and silently, is interfering with a biological system that your blood vessels depend on. NSAIDs work by blocking specific enzymes involved in producing inflammatory signals. That's why the swelling and pain ease. But those same enzymes also help regulate the protective function of your blood vessel lining. When NSAIDs suppress them, the lining of your arteries loses some of its ability to stay relaxed and responsive. Blood vessels tighten. Blood pressure climbs. Not dramatically, not overnight, but steadily. And at the same time, NSAIDs affect how the kidneys manage sodium and water. The body begins to retain more fluid. You now have two forces acting on your cardiovascular system simultaneously: higher pressure in the vessels and more volume moving through them. For a heart that is already working harder after 60, that combination adds a load that accumulates over time in ways you are unlikely to feel until the system can no longer silently compensate. Large studies across tens of thousands of patients have confirmed that prolonged or frequent NSAID use in older adults is associated with measurably higher rates of heart attack and stroke. The mechanism isn't mysterious or theoretical. It is as biological and real as the pain the pill was meant to treat. Short-term, carefully monitored use may well remain appropriate, but daily, long-term use of NSAIDs after 60, without anyone asking whether that calculus still makes sense, is one of the most common and most underestimated cardiovascular risks in modern life. The second medication surprised most people when research first began drawing the connection, and it still surprises most people today. Proton pump inhibitors, or PPIs, are prescribed for acid reflux, chronic heartburn, and to protect the stomach lining in people taking other medications. Names like omeprazole and esomeprazole are among the most recognized in any pharmacy, and their safety profile, on its surface, looks reassuring. They reduce acid, they relieve discomfort, they prevent ulcers. What they also do, quietly and over time, is reduce the stomach's ability to absorb 3 nutrients that your cardiovascular system cannot function well without: magnesium, calcium, and vitamin B12. Magnesium governs the electrical stability of the heart. When magnesium levels fall, heart rhythm becomes more vulnerable to disruption. Irregular rhythms, some of them dangerous, become more likely. Calcium balance is intricately tied to how blood vessels function, and vitamin B12 is essential for maintaining the health of the vessel walls themselves and the nerves that regulate cardiovascular function. Beyond nutrient depletion, some research has pointed toward a more direct effect. Long-term PPI use may affect the functional capacity of the endothelium, that inner lining of blood vessels we discussed earlier. When endothelial function is impaired, vessels become less able to dilate appropriately, clotting becomes more likely, and the risk of cardiovascular events increases. The deeper issue here is not simply the pharmacology, it's the pattern. Someone begins a PPI for a temporary problem. The problem resolves. The prescription continues because nobody stopped to ask whether it should. Months become years, years become a decade of mild but consistent nutrient depletion that the cardiovascular system absorbs quietly until it can't. Now we move into territory that feels more emotionally complex, because the third medication on this list is one that many people over 60 rely on, not just for comfort, but for functioning. Benzodiazepines, a class of medications that include diazepam, lorazepam, and several similar drugs, are prescribed for anxiety, insomnia, nervous system dysregulation. They work, genuinely. The calm they provide is real. The sleep they enable for people who would otherwise lie awake for hours is real. And for many people, that relief felt like regaining a piece of life they had lost. But the cardiovascular risk that builds around long-term benzodiazepine use after 60 is real too, and it operates through a mechanism that almost nobody thinks to connect. As we age, sensitivity to these medications increases significantly. The same dose that produced mild sedation at 50 produces more profound sedation at 65. The drug clears more slowly, effects accumulate. And one of the most direct consequences of that deepened sedation is reduced physical movement. Not in a way that feels like paralysis or disability, in a way that feels like tiredness, like heaviness, like a reasonable preference for the couch over the walk. But circulation depends on movement. The cardiovascular system was designed to work in partnership with a body that moves. When that movement decreases, blood pools more easily. Clot risk rises. Oxygen delivery to tissues becomes less efficient. And there is another layer. Benzodiazepines affect breathing during sleep in ways that compound over time. They relax the muscles of the throat and respiratory system, worsening or in some cases creating sleep-related breathing problems. Every night that oxygen levels drop slightly during sleep, the heart absorbs that strain. Repeat it hundreds of nights in a row, and the cumulative pressure on an aging cardiovascular system becomes something that can no longer be called insignificant. What makes this particularly challenging is that the risk and the symptom feel identical. Both look like fatigue. Both look like slowing down. The medication that was prescribed to improve quality of life can, over years, quietly reduce the body's capacity without anyone recognizing the connection. The fourth medication is one that hides effectively behind its own ordinariness. Decongestants, including the pseudoephedrine found in many common cold and sinus medications, are sold without prescriptions in most countries and carried by people who would never describe themselves as taking heart medication. And yet, their mechanism of action is fundamentally cardiovascular. Decongestants reduce nasal congestion by causing blood vessels to constrict. Narrower vessels in the nasal passages mean less swelling and easier breathing. But blood vessel constriction does not stay neatly contained to the sinuses. It affects vessels throughout the body. Blood pressure rises, heart rate increases, the heart works harder against a tighter vascular system. For a younger person with elastic, responsive arteries, this is typically a manageable and short-lived effect. For someone over 60 with blood vessels that are already less flexible and possibly already managing elevated blood pressure with medication, the additional constriction from a decongestant creates a compounding strain that the body may not absorb without consequence. And this is where combinations become the central danger. No one over 60 is typically taking just one medication. There is usually a blood pressure drug, perhaps a pain reliever, perhaps something for sleep, perhaps a stomach protectant, each one added at a time when it seemed necessary and appropriate. And then, during cold season, a decongestant is added to the stack. Each drug in isolation might have been manageable, but stacked together, one raising blood pressure while another affects fluid retention and another alters vessel tone, the system faces a challenge that is far greater than the sum of its parts. The cardiovascular event that follows this kind of compounding strain is almost never attributed to the cold medicine. It's called a sudden event, but the groundwork for it was laid over time, through medications that were never reviewed together as a collective burden on one aging body. The fifth medication is the one that tends to land with the most surprise and deserves the most careful and nuanced explanation: low-dose aspirin. For decades, it was presented as one of the simplest and most accessible tools in preventive cardiology. A small daily tablet that reduced the stickiness of platelets, making it harder for dangerous clots to form inside arteries, reducing the risk of heart attack and stroke. Millions of people began taking it based on this guidance and continued for years, for decades, treating it as a permanent fixture of responsible self-care. The science, however, evolved, and what it revealed was something more complicated than the original messaging suggested. Aspirin's mechanism is real, and its benefit in the right population is genuine. For someone who has already experienced a heart attack or stroke, or who carries a specific pattern of high cardiovascular risk, daily aspirin remains an important and supported therapy. But for the broader population of adults over 60 who began taking it as a preventive measure without a prior cardiovascular event, the picture shifted considerably. The same anti-clotting effect that protects against one kind of stroke increases vulnerability to another. There are two distinct categories of stroke, one caused by a blood clot blocking a vessel, and one caused by a vessel bleeding into brain tissue. Aspirin reduces the risk of the first. It increases the risk of the second. After 60, as blood vessel walls become more fragile and the lining of the digestive tract becomes more sensitive, the bleeding risk from daily aspirin rises meaningfully. Major guidelines in cardiology have been updated in recent years to reflect this shift, moving away from routine aspirin recommendations for older adults without established cardiovascular disease. But millions of people were never informed of this change. They are still taking a daily aspirin that was prescribed under older guidance, assuming it is protecting them, unaware that the current evidence may tell a different story for their specific situation. Here is the thread that connects all 5 of these medications, and it is the most important thing in everything we have discussed today. None of them are bad. None of them are reckless prescriptions made by careless physicians. Each one had a legitimate purpose at the time it was recommended. Each one can still be appropriate under the right circumstances, for the right person, at the right dose, with the right monitoring. The problem is not the medications. The problem is the assumption of permanence, the assumption that what made sense when it was prescribed continues to make sense indefinitely, regardless of how the body has changed around it. Medicine is a tool, not a fixture, and like any tool, its usefulness depends entirely on whether it is matched to the current job. After 60, the job has changed, the body has changed, and the tools being used need to be evaluated against that new reality, regularly and honestly, with someone who knows your full picture. So here is what actually makes a difference, not in theory, but in practice. At your next medical appointment, bring every medication you take, including over-the-counter pills, supplements, and anything taken only occasionally. Ask one simple question. Is everything I am currently taking still the right choice for me at this stage of my life, at my current age, with my current health? That question changes the dynamic of the conversation entirely. It shifts it from reactive to proactive, from managing symptoms to genuinely evaluating the full system. It opens a door to adjustments, simplifications, or replacements that might reduce your cardiovascular burden without removing necessary support. And learn to notice the quiet signals your body sends before anything dramatic occurs. Fatigue that doesn't match your activity level. Shortness of breath during tasks that once felt easy, lightheadedness when you stand, blood pressure readings that seem to have drifted, sleep that feels less restorative than it used to. These are not inevitable features of aging. They are often early communications from a system under more strain than it should be, a system waiting for someone to listen carefully enough to notice. The gap between a cardiovascular event and a near miss is often not a dramatic intervention or a new medication. It is a series of small, informed adjustments made before the pressure became too much to silently absorb. You have more influence over that process than most people realize. And it begins not with fear, but with the simple and powerful act of asking better questions about the pills you take every single day.